This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Deanna Saylor from the Johns Hopkins University School of Medicine. I'm the editor of Without Borders, Neurology's Global Health section. Today, we have Mayowa Owolabi joining us. Mayowa is a professor of neurology, director of the Center for Genomic and Precision Medicine, and former dean of the Faculty of Clinical Sciences at the University of Ibadan in Nigeria. He is also a senior stroke researcher and lead co-author of a recent paper published in Lancet Neurology titled Pragmatic Solutions to Reduce the Global Burden of Stroke, a World Stroke Organization Lancet Neurology Commission. It was published on November 15th, 2023. Thanks for joining us today, Mayowa.
Thank you so very much for this great honor.
We are likely all intimately familiar with stroke as a clinical entity, but may not be as familiar with considering stroke in the global sense. So I thought maybe we could start today. If you could just tell us a bit about the global burden of stroke and more about why the World Stroke Organization and Lancet Neurology formed the Global Stroke Commission.
We know that up till now, stroke is the second leading cause of death globally. And more so, stroke is a leading cause of neurological disability. It's also a leading cause of dementia and a leading cause of depression. So, when you look at the burden of stroke, you will see that right now, each year, about 6.6 million people suffering from stroke. And it is projected from the work of the Lancet Commission that by 2050, this is going to increase to about 9.7 million. That's almost 50% increase. Most of this increase is going to happen in LMICs. Right now, 86% of the burden is borne by low and middle income countries in Asia, in Africa particularly. And this is going to increase to 91% of the entire burden being borne by low and middle income countries. The truth of the matter is that as a neurologist working in Nigeria and elsewhere, I got confronted by stroke on a daily basis. More than half of neurological admissions in many places are from stroke, and it is not abating. For instance, in Nigeria, every minute at least a Nigerian suffers a stroke. In Africa, every minute at least 6 Africans suffer a stroke. What have we found? We found that most of this is due to the emerging burden of risk factors like hypertension that is undetected, undiagnosed, or when detected and diagnosed is not treated, is not controlled. Same thing with obesity, same thing with diabetes. And stroke in the young is also increasing, particularly in low and middle income countries, where hemorrhagic stroke is still a critical mass, still a high proportion. For instance, stroke in the young, in Africans, we found that 52% of those are actually hemorrhagic. So it is a major health problem that is deserving very little attention. And then I brought up this idea, which actually I had proposed before in 2011, the stroke quadrangle. I know that most of the time our attention, particularly those of us that work in hospitals, is focused on acute care, which is just the tip of the iceberg, to the exclusion of prevention, which is actually very important and is the best bet, to get the burden to reduce the burden, particularly in LMICs. The best bet is prevention, even though acute care is still important whenever it occurs. So, and then, of course, the other pillar is surveillance and research, because without surveillance and research, understanding the burden, understanding the trends, understanding the risk factors is difficult to plan, and is difficult to plan any intervention, including prevention, including acute care. And of course, rehabilitation is very important to restore health as much as possible, improve well-being, improve quality of life, very related quality of life, and ensure the person is still productive, still able to integrate to society, and still able to live a meaningful and productive life. So those are the 4 pillars that were proposed. And then we have to go through a situational analysis, surveying stroke services across 84 countries, and that got published.
Clearly, this was an immense amount of work involving so many moving parts and such a comprehensive approach to the problem. And I just commend you and your colleagues for all of that to highlight solutions through those 4 pillars of the stroke quadrangle, the prevention, acute care, rehabilitation, and surveillance and research. And you already mentioned that for surveillance, you think that it's really important to have kind of local research that can guide the interventions that need to be done to then improve prevention, improve acute care, and improve rehabilitation. Focusing on the other pillars for prevention, the suggested solutions that you highlight include primary and secondary stroke prevention, as well as public awareness campaigns to promote various lifestyle modifications. And this applies to all stroke risk factors, as we know, but hypertension is particularly highlighted. I wondered if you could talk to us again from kind of a global perspective about why you think hypertension is so important to address.
Hypertension is the strongest modifiable risk factor for stroke. So it's really the elephant in the room. And the major problem now with hypertension is that it is often silent. Many people are hypertensive without knowing that they are hypertensive. If I'm going to use Africa to illustrate, only 7%, and you'll be surprised, only 7% of those who are hypertensive in Africa are aware, on treatment, and controlled. The remaining 93% are either not aware because it may be no symptoms, or they are aware, they are not on treatment, or they are on treatment, they are not controlled. So it's a major issue. And rhetorically and jokingly, but also futuristically, I know that we're in the era of genomics, multiomics, synthetic biologics, and all of that. I know that control of hypertension, detection, control of hypertension is a major issue, even across the globe, including even in the US or high-income countries, because of its asymptomatic nature. And so even the control rates in the US and in other places are not as impressive as one would have wanted it to be. And that's because the treatment is for life, for life. People have to take pills every day for life. And for life, we tell them, well, it's for life. Some people have to take many pills many times a day, which makes it tough. And we say, okay, maybe poly pills may help for those who need to use multiple pills. Maybe poly pill may help, which is like combining treatment for dyslipidemia, which some of them also have, with a single drug tablet for single pill for hypertension. Maybe that could help. But beyond that, even though that's not the solution right now, but I'm sure it's going to happen at some point in time, it would have been nice if at some point you're able to give an injection, maybe any of these synthetic drugs which would come up, later on, that is actually like a cure. But before that happens, we must ensure that from the age of maybe even 20 or so, people get screened, at least annually. Those who are detected are treated through universal health coverage. And then hypertension may also be preventable in terms of primordial prevention of stroke. And that has to do with lifestyle, reducing salt intake, increasing vegetable consumption, reducing fast food, junk food, commercial determinants of health, social determinants of health, political determinants of health, lifestyle, increasing exercise, maintaining a healthy body weight. All of these are very important in reducing the burden of hypertension. From the age of, say, about 20, people need to check their blood pressure. Maybe government should make that mandatory. Maybe government should make the opportunity for this to happen. Make sure those opportunities are available. Dyslipidemia is coming on the heels also as a very, very predominant or dominant risk factor for stroke. It wasn't the case before, but it's now one of the major reasons. Diabetes, obesity, then lifestyle, smoking, alcohol, so cardiac diseases, atrial fibrillation, particularly with increasing age. If you're able to deal with the risk factors, identify, characterize, deal with the risk factors, you are likely to be able to deal with primary prevention, and of course, reducing the burden. And you can prevent those risk factors by having a life course, whole of government approach that includes even the educational sector, pupils being taught about healthy lifestyle, healthy weight, healthy diets, and then they go into their household as apostles, as advocates, as ambassadors of healthy living in their families. 60-70% of strokes are preventable. And that is why we need to put all hands on deck, to ensure this is done. It's everybody's business because everybody is at risk of stroke. 1 in 3 has a lifetime risk of stroke. Lifetime risk of stroke is 1 in 3. So it's something everybody needs to deal with.
I think what you've raised is so important, Mayowa, that the majority of strokes can be prevented. And I love that in this era of kind of designer drugs and biologics and expensive new therapies, you're focusing on blood pressure checks, and very basic things that when applied at a population level can make such a huge difference. You talk about in your acute care pillar that the importance of establishing stroke units, which many people in the US and other high-income countries may take for granted, but the fact that stroke units are absent from many regions of the world, and reperfusion therapies and thrombectomy and other kind of interventional therapies are even less available and out of reach for most of the world's population. But I want to turn now to the last pillar for rehabilitation. Your group talks about training community health professionals and caregivers in stroke rehabilitation strategies. So I wonder if you just have any examples of successful projects in this area that you wanted to highlight.
Neurorehabilitation or rehabilitation of stroke is by definition is multidisciplinary. By definition, has to be, because the deficits, the disabilities, the functional restrictions or participation restrictions are along different lines, different facets. Because, stroke affects the brain, and the brain controls many things, including communication, speech, language, including mobility, hand use, and so on and so forth, cognitive function. So when someone comes down with stroke, you may have many of these faculties affected all at once. And therefore, it becomes mandatory to have multidisciplinary care. But the truth of the matter about multidisciplinary care is that it requires different professionals, like, neurologists, speech and language therapists, otherwise called speech pathologists in the US, cognitive therapy offered by clinical psychologists, of course, physiotherapy, nursing care, specialized nutritional care, occupational care, and all of that. And the truth of the matter is that in many places, even neurologists, and I know you know this very well, in Africa, there are countries without even a single neurologist. You'll be surprised that some countries don't even have physiotherapists, language therapists, and so on and so forth. So, meaning then, therefore, that given the high burden of those who require these services, and the fact that even if we want to train these specialists, it should take some time, years, 3, 4, 5 years to train them, we then have to utilize task shifting. We really don't have an option, and task sharing. And even where there are physiotherapists, they cannot give the intensity, duration of therapy that is required for effect per person. Because for instance, you need up to 3 to 6 hours of physiotherapy per day, to get the best out of physiotherapy sessions for patients with stroke. But then that would mean that a physiotherapist cannot see more than 2 or 3 patients in a day. So inevitably, we then must adopt task shifting, task sharing. Now, the easiest way we've done that in LMIC settings, including Nigeria, is to work very, very closely with the caregiver. But of course, we know this has its own challenges. The caregivers are also going through stress. Some of them have to stop what they are doing, take leave from work. They are handling a lot of financial, psychological, physical stress. And then to now also ask them to participate in the care process, bearing part of the burden of care is also an issue. So, but it has to be worked out in such a way that we know what they can cope with, and they are able to offer that as needed, as required, to improve the practice, the number of hours of practice by the patient, and help the patient, encourage the patient, motivate the patient to improve. So the caregivers are the best bet. Now, getting people in the communities is more complicated and more difficult, but we are actually working on that with the World Federation for Neurorehabilitation. There is a community-based rehabilitation program, which it has always been one of the ideas of WHO, to make these services, community-based rehabilitation, available at primary health care centers, and to train people who can offer some of this in a regulated manner, so it doesn't become quackery, with some form of supervision and referral system built into it. But the truth of the matter is that the only way to go right now to ensure that people that require rehabilitation services, multidisciplinary rehabilitation services, are able to get some modicum of that, sufficient practice and sufficient exposure that helps them to progress along the lines of recovering back function, improving quality of life, and restoring the ability to participate in society and contribute to society in terms of work roles, family roles, and so on and so forth, is to ensure that they're able to have some middle level people, either family members or community members who are able to bridge the gap and assist them. So this is happening in an informal way, but working with different stakeholders, I'm sure this can even work better. And of course, we still need to increase the global workforce for neurorehabilitation by training more people, attracting more people into the field of neurorehabilitation, training more neurologists, more physiotherapists, more speech and language therapists, more psychotherapists, more occupational therapists, and so on and so forth, nutritionists, rehabilitation nurses, and so on and so forth, that can help people navigate their way out of stroke. Whenever stroke strikes, it's really a life-changing event with catastrophic spending, a lot of indirect costs, direct costs to the family, and so on and so forth. So helping them to, at their weakest point, to come out of this, is a major challenge to all of humanity. And I think we owe people who have suffered a stroke this duty. In as much as we owe those who are yet to have a stroke, help them to prevent stroke, because the 99% of those that are at risk, people we can deal with, and 60 to 70% of them we can make sure they don't eventually develop a stroke. Because if 1 out of every 3 human beings on the planet are at risk of stroke, lifetime risk of stroke, that's a huge thing, and we can deal with it. And the collateral benefits is that while preventing stroke, we will be preventing heart attack, we will be improving brain health, preventing dementia, and we will also be preventing even other non-communicable diseases, including cancers, which share similar risk factors. So, and stroke is perhaps the gateway through which we can canvass for hypertension control, because people don't see the benefit of hypertension detection, treatment, and control of its own. But if you're able to say, look, this is something that may cause a stroke, then it rings a bell, and perhaps they are motivated positively to do something about it. Thank you so very much for the opportunity to talk about this.
Thank you so much, Mayowa. I think you've raised such important points today. You've certainly highlighted the many barriers there are in both optimally treating and also preventing stroke, not just in low and middle income countries, but really globally. To learn more about the World Stroke Organization, Lancet Neurology Commission's recommendations for reducing the global burden of stroke, Professor Owolabi's paper was published in Lancet Neurology on November 15th. I'm Deanna Saylor, and I've been joined today by Mayowa Owolabi. Thanks again to everyone for joining us today, and please join us again soon for the next Neurology podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.